Hello, this is Chad Golly, and I chose my Pecha Kucha presentation topic of chronic pain and suicide. Why? I'm not too sure. I'm not a morbid person, but maybe it's because I had a patient about a couple of weeks ago that said that they were ready to end it all because they were sick and tired of their pain. Who knows? Suicide ideations, suicide attempts, and suicidal completions are very common comorbidities among chronic pain patients. Also to note, chronic pain may be a risk factor for suicide, and pain is a strong predictor for suicidal ideations. It is a sad reality, but this is the profession we have chosen. The stats on suicide and chronic pain are astonishing. There are over 34,000 suicide deaths every year, and more than 376,000 people are seen in the ER annually with self-inflicted injuries. In a chronic pain patient's lifetime, the frequencies of suicide attempts are between 5 and 14%. Compared to the general population, suicide completion rates in chronic pain patients are 2 to 3 times greater, and people with chronic pain have a considerably higher incidence of depression. 20% versus 9%, post-traumatic stress disorder 10% versus 3%, and any anxiety disorder 35% versus 18%. Elgin and colleagues conducted the largest non-cancer pain study to date, over 4.8 million patients. They evaluated associations between various pain diagnosis and suicide among patients treated at VA facilities. These diagnoses included arthritis, back pain, migraines, headache, neuropathy, fibromyalgia, and psychogenic pain. What they found out was that every condition except arthritis and neuropathy, suicide mortality was elevated, the diagnosis of psychogenic pain being the most at risk for suicide. These findings suggested that there are differences among different pain conditions and that musculoskeletal pain has an increased risk for suicide even after evaluating for psychiatric disorders. These researchers also examined 88 patients at various pain clinics, where they found out that 24% of these patients reported active or passive suicidal ideation. In a similar study, 153 patients with chronic pain, 19% had passive suicidal ideations, 13% had active ideations, 5% had a plan for suicide, and 5% had a past history. As we all know, opioid fatalities have been on the rise. From 99 to 06, these deaths tripled from 4,000 to 13,000, and 40% of all deaths by poisoning in 2006 were from opioids. It was unclear if these were unintentional deaths, but between 05 and 07, the ERs saw a 30% rise in drug-related attempts. There are several risk factors for suicidal ideations. They include having family histories of suicide and/or sexual abuse, a previous history of attempts, being unemployed or disabled, poor sleep quality, self-perceived mental health status, pain-related sense of helplessness, easy access to lethal methods, and a history of alcohol and substance abuse. In a recent study, 52 psychiatric inpatients that were admitted because of suicidal ideation were examined regarding what their thought processes were of suicide. The question was then asked, why suicide? They came to find out that 7 isolated response types were given within this study. Suicide was seen as an easy way out, a permanent solution to a problem. It was related to hopelessness. There were relationship issues that provoked their thoughts. They felt that it was the only option. They were self-oriented or selfish, and they viewed it as an escape from all the pain. Since we are in the business of treating pain patients, I think it's very important that we be aware that some of our patients may possibly be showing signs of suicidal thoughts. In all honesty, we could be the very last person that this patient ever talks to or ever sees, has any contact with. There are 10 warning signs that show that a chronic pain patient may be thinking of committing suicide. These are: their screening scores indicate moderate or more severe depression. These patients have an increased pain intensity and duration. They demonstrate social isolation and withdrawal. They exhibit poor sleep quality. They present with a decline in function and grooming. They exhibit catastrophizing and feelings of being a burden or a liability to others. They have a pain-related sense of helplessness. Their drug screens show an absence of prescribed opioids, suggesting that they are hoarding their medications. And lastly, they have an unwillingness to contract for safety. Intervention is key with this patient population. I believe a thorough history and the use of screening tools should be employed with every patient that walks through the clinic door. These screened patients with moderate to high levels of depression, with or without suicidal thoughts, should be referred to a specialist for co-treatment. There are also some things you should take into consideration, like if they have vague or specific plans to carry out suicidal plans, whether or not they have a history of previous attempts or if they exhibit impulsive behavior, if they have support from their friends and family, and if they have coping skills. Within acute suicidal phase, aggressive pharmacotherapy for both depression and sleep deprivation should be used along with psychology and family involvement. The patients needing opioid therapy should only be prescribed in small amounts and given to them by one of their family members. Regular urine drug screens should be performed to make sure there is therapy adherence. Those patients that have had chronic suicidal ideation are deemed high risk, and psychotherapy and psychiatric care should be initiated along with their pain management care. There are several suicide cognition scales out there to help us aid in our practice, such as the Patient Health Questionnaire, the Beck Scale for Suicide Ideation, and the Beck Hopelessness Scale. There are others out there, but however, I'm running out of time. So therefore, I urge you to look up some of these and find which one you deem suitable for your own personal clinic setting. I believe with the right tools and resources, we will be better suited to help these particular patients in our practice. Thank you for your time and have a great day.